So pelvis is a lower division of the abdominal cavity and that resembles a basin. Pelvis equal to basin in Latin. It comes from this Latin word. Pelvis is subdivided into two parts, greater pelvis and lesser pelvis by the pelvic inlet or pelvic brim. So the pelvic brim is bounded anteriorly. This is very frequently asked in your viva in bones table. Okay, describe the pelvic brim. Okay. So pelvic brim is bounded anteriorly by the upper margin of pelvic brim is bounded anteriorly by the upper margin of pubic symphysis on either side by the pubic crest, pectineal line, arcuate line and anterior border of ala of sacrum and posteriorly by the sacral promontory. So all these structures are forming the pelvic brim. Greater or false pelvis lies above the pelvic brim and it contains the sigmoid column and coils of the ilium. Okay. So these are the content of the false pelvis. Next we go to the, false pelvis lies above the pelvic brim and true pelvis lies below the pelvic brim. Okay. So next we go to the true pelvis or lesser pelvis. False pelvis is also known as greater pelvis and true pelvis is also known as lesser pelvis. So the true pelvis lies below the pelvic brim and it is enclosed within the bony walls formed by the sacrum, coccyx and hip bones. We will discuss the walls of the true pelvis in details. So the true or lesser pelvis has these following walls and they are made up of bones, muscles and ligaments. First we go to the anterior wall. Anterior wall is the shortest wall and it is bounded by the pubic symphysis and the bodies of the pubic bones. Next we go to the posterior wall. It is the longest of all the walls and it is bounded by pelvic surface of sacrum, pelvic surface of coccyx, piriformis and the fascia covering the piriformis. Okay, so all these structures are forming posterior wall. Next, see, this is the anterior wall formed by the pubic symphysis, posterior surface of the pubis bone, body of the pubis bone. Okay, and these are the pubic rami, obturator membrane. This is ischio pubic rami. Okay, next we go to the lateral walls. Lateral walls are formed by pelvic surface of the hip bone here. This is lateral wall, pelvic surface of the hip bone below the pelvic brim. So this line was forming pelvic brim. Below this part is forming the lateral wall of the pelvis. Obturator membrane. This is obturator foramen covered by the obturator membrane and this is muscle, obturator internus with its covering fascia. So obturator internus and its fascia and sacrotuberous and sacrospinous ligament. Here is the sacrospinous ligament and this is sacrotuberous ligament. All these are forming the lateral wall of the pelvis, true pelvis. Next we go to inferior wall or pelvic floor. It is also called pelvic diaphragm and it is formed by Levator Ani and coccygeus muscles and fascia covering them. The pelvic diaphragm separates the pelvic cavity from the perineum. Okay. Next we go to the contents of the true pelvis. These are the contents: sigmoid column, rectum, urinary. This is GI system, part of the GI system. Next, this is urinary system, urinary bladder and ureter. And this is genital system. In male, prostate, ductus deferens and seminal vesicles. In females, there will be uterus, uterine tube, round ligament of uterus, ligament of ovary, ovaries, vagina. So all these are content of the true pelvis. Next, there is nerves and vessels, peritoneum and there is pelvic fascia. Okay, so all these are content of the true pelvis. Here you can see this is the bone attached to this bone. This is the muscle. These are the different nerves, Pelvic fossa, here are the vessels. Vessels are passing through the mesentery, also nerve is passing through the mesentery and supplying the pelvic viscera. And this is peritoneal covering, parietal peritoneum. Okay. And covering the viscera is the visceral peritoneum. Next we go to the muscles of the pelvis. You have seen muscles in the posterior abdominal wall that you have seen, also we have discussed in class. So today we will know about muscles of the pelvis. So the muscles of the pelvic wall are Obturator Internus, Piriformis, Levator Ani and Coccygeus. Obturator Internus, it is a fan-shaped muscle, arises within the pelvis and its tendon leaves the pelvic cavity through the lesser sciatic foramen. Its origin, it arises from pelvic surface of the obturator membrane and adjoining bones surrounding the obturator membrane. What is the insertion? The tendon of the obturator internus stands almost at a right angle at the lesser sciatic notch, and further it crosses the posterior aspect of the hip joint and insert into the medial surface of greater trochanter of the femur. So this is the insertion of the obturator internus. It is supplied by nerve to obturator internus, which is a branch of sacral plexus, and these are the root values L5, S1, S2. Actions. It is a lateral rotator of the hip joint in erect posture and acts as an abductor of the hip joint when the thigh is flexed, and it is stabilizes the hip joint. So this is function of the obturator internus. Next, see here, this one is the obturator internus. Okay, arising from the origin from pelvic surface of the ischial spine, tendinous arch of obturator fascia, pelvic surface of body of the pubis. And here you can see also coccygeus. This is coccygeus muscle, and this is piriformis, and here is the levator ani. Okay. So coccygeus origin is from apex of ischial spine, sacrospinous ligament, insertion into the side of the last piece of sacrum and upper two pieces of the coccyx. This insertion you have seen during discussion of the sacrum. Okay. Next see these muscles we have seen in the gluteal rhythm. Some part of these muscles are also lying within the pelvic cavity. They are really coming out from the pelvic cavity, entering into the gluteal region. This is piriformis coming out through the greater sciatic foramen, and these are the three muscles. This is tendon of the obturator internus, superior and inferior gemelli. They are together forming the tricipital tendon. Here is the origin of obturator internus, obturator membrane and adjoining bones. And here is the insertion of this muscle. Okay. At the apex, there is insertion of piriformis, and just posterior to the apex, here is insertion of these three muscles, two gemelli and tendon of the obturator internus. And here is the origin of the piriformis, middle three piece of the sacrum. Okay, and also from this greater sciatic notch, upper margin of greater sciatic notch, and here is insertion near the apex of the greater trochanter of the femur. Okay, this is insertion of the piriformis. Next, so obturator internus origin from obturator membrane, bones adjoining the obturator membrane, insertion into the medial surface of greater trochanter of femur. Innervation is by nerve to obturator internus, and action is lateral rotation of hip joint, abductor of the hip, and stabilizes the hip joint. So these are the functions of obturator internus. Next, obturator membrane closes the obturator foramen, and it gives origin to obturator internus from its pelvic surface and obturator externus from its outer surface. And this obturator fascia, it is a semi-transparent fascia covering the pelvic surface of the obturator internus. Tendinous arch of levator ani or white line. What is it? It is a arc-shaped linear thickening of the obturator fascia, and that gives rise to levator ani muscle. It extends from body of pubis to the ischial spine, and this arch divides. This is the extent of this tendinous arch, and it divides the cavity into two parts. Okay, there is some fossas, divisions of fossa, istiorectal fossa, like this. Okay, next we go to the piriformis, or also known as piriformis. It is a pear-shaped muscle, and that forms the posterolateral wall of the true pelvis. What is the origin? Arises within the true pelvis from the anterior surface of middle three pieces of sacrum by three digitations. Few fibers arise from the upper margin of greater sciatic notch, and this is the direction of fibers. The fibers run downward and laterally to form a tendon, and it leaves the true pelvis through the greater sciatic notch to enter in the gluteal region. And here the tendon lies deep to the gluteus maximus muscle. Insert at the tip of greater trochanter of femur. Innervation, it is supplied by ventral primary rami of S1 and S2 nerves. Actions is stabilizes the hip joint, acts as lateral rotator of the hip when thigh is extended, and as adductor when thigh is flexed. Okay. This is action of the piriformis. Next we go to Levator Ani. So this is piriformis. Here is coccygeus, and these three muscles together is forming the Levator Ani. Okay, and it is arising from this tendinous arch. This green line is the tendinous arch, which is formed by thickening of the obturator membrane, and here on the medial aspect it is attached to the anococcygeal ligament. Okay. So this iliococcygeus, pubococcygeus, puboanalis, all these are together forming the levator ani. So levator ani formed by this pubococcygeus, iliococcygeus, and puboanalis. Levator ani is a broad, flat muscle forms the larger part of the pelvic floor, and it is divisible into three parts: pubococcygeus, iliococcygeus, and puboanalis. Both the levator ani, right and left side, slope from the side of the pelvic wall towards the medial plane, where they fuse with each other, and thus it forms a sloping gutter-like floor of the true pelvis and separates it from the istioanal fossa. Okay. Istioanal fossa lies around the anal canal. So we will discuss these three parts in details. First is pubococcygeus. This part is pubococcygeus. Okay, it is subdivided into puboperinealis or pubourethralis, puboprostaticus or levator prostatic, pubovaginalis, and puboanalis parts. Okay, pubovaginalis is lying in female, puboprostaticus in male, and these puboperinealis or urethralis, these are lying in both of the sexes. Also, this puboanalis is lying. Next, so pubococcygeus originates from the posterior aspect of body of the pubis. Here, this is pubis. So posterior aspect of body of pubis, it is arising. Then direction of fibers and their subgroups. Puboperinealis or pubourethralis, these are medial fibers of pubococcygeus. They that run lateral to the urethra. See here, this is urethra, this is vagina, this is rectum. So this puboperinealis, it passes parallel to the runs lateral to the urethra and has no direct connection with the urethra. So these medial fibers are puboperinealis. Next is puboprostaticus or levator prostatic. In male, some of the fibers of pubococcygeus lie inferolateral to the prostate, and these fibers form the puboprostaticus part. Next is pubovaginalis. In female, some of the fibers of pubococcygeus attach to the lateral wall of vagina to form pivovaginalis or sphincter vaginalis part. Next is pivoanalis. In both sexes, some middle fibers of pivococcygeus decussate and blend with the longitudinal muscle coat of rectum to form the pivoanalis part. What is the insertion? Remaining posterior fibers of pivococcygeus insert on the levator raphe or anococcygeal ligament. So this is the insertion point, anococcygeal ligament, and tip of the coccyx. Here is the tip of coccyx. Next we go to iliococcygeus. This part is iliococcygeus. Origin is from posterior part of tendinous arc of Levator Ani, that is white line on the obturator fascia. We have discussed previously. And inner surface of the ischial spine. So this is the origin. Insertion, most of the fibers insert on the median raphe of the Levator Ani and anococcygeal ligament, and posterior fiber insert on the tip of the coccyx. Next we go to pivoanalis. This is pivoanalis. Okay. The fibers are not visible from inside the pelvis. Origin, it originates from the inner surface of ischiopubic ramus adjacent to the attachment of perineal membrane. And insertion, the fibers of pivoanalis pass posterior to the rectum. You can see it is passing posterior to the rectum at the anorectal junction and decussate with the contralateral fiber. These are the contralateral fibers. Innervation by the perineal branch of S4 nerve and perineal branch of pudendal nerve S2, S3. Okay, so these are the nerve supply of this muscle. Next, what are the actions? Support both the levator ani form pelvic floor and support the pelvic viscera. Okay. They prevent herniation of the pelvic viscera through the different openings. Okay. When the levator ani gets weakened, there is uterine prolapse. Okay. It is a important support for the uterus, an important support of the pelvic floor. Also, anal canal can also collapse if this levator ani get weakened. Okay. So, it acts as a support both the levator ani form pelvic floor and support the pelvic viscera. Fixation of perineal body. Some fibers of levator ani insert on the perineal body and they fix the perineal body to support the pelvic viscera. Next is resistance against increased intra-abdominal pressure. Levator ani supports the pelvic viscera in increased intra-abdominal pressure during coughing, sneezing, lifting of heavy objects, and so on. And relaxation of levator ani assists the micturition and defecation. Reinforcement of external anal sphincter by maintaining the anorectal angle by the pivoanalis and pivococcygeus. They pull the anorectal junction forward. You can see this sling-like muscle. Both of the muscles join posteriorly to form a sling, and this sling pulls the anorectal junction forward. Okay, this pivoanalis. Next. So, piriformis, summarization of piriformis. Origin is from anterior surface of middle three piece of sacrum and upper margin of greater sciatic notch. Insertion into the tip of greater trochanter, innervation by S1 and S2 nerves. Action is stabilization, lateral rotation and adduction of the hip joint. Okay, so this is function. Next, coccygeus. Piriformis is very commonly given OSCE question, okay, in gluteal region. So you have to know these 4 points: origin, insertion, nerve supply, action. Also there is one piriformis syndrome that we have discussed during the infex, that also important clinical aspect. Okay. So this is also important for your theory. Can come as a short note, piriformis. So coccygeus and ischio-coccygeus, it is a small triangular muscle and some authors consider it as the posterior most part of levator ani and some consider as a separate muscle. Origin, it originates from pelvic surface and tip of ischial spine. Insertion, the fibers pass horizontally backward and medially and insert on the lateral border of the coccyx and upper part of the sacrum. Innervation supplied by ventral primary rami of S4, S5 nerves. Action, it assists the actions of levator ani, pulls the coccyx forward after it has been pressed backward during defecation and parturition. Okay, next. So coccygeus origin is from ischial spine. Insertion is into the lateral border of coccyx and lower part of the sacrum. Innervation by S4 and S5 nerves. Action is assists the levator ani, helps in defecation and parturition. Okay, next. Pivo visceralis equal to pivo perineus or plus pivo vaginalis or pivo prostaticus plus pivo analis. So these are the three parts of the pivococcygeus. Next is morphology of the pelvic diaphragm. Sacrospinous ligament is degenerated aponeurosis of ischio-coccygeus muscle, and in lower animals the movement of the coccygeal vertebra and tail is performed by this pivococcygeal and iliococcygeal part. Okay, next. Pelvic diaphragm. Pelvic diaphragm is important, short note. Okay, this is also asked in your viva, how many diaphragms are present in our body. Okay, three diaphragms are, main diaphragms are present. The diaphragm separating the thoracic cavity from abdominal cavity, oral diaphragm lying in the floor of the mouth, and this is another diaphragm, pelvic diaphragm. Okay, lying in the perineal region, supporting the pelvic viscera. So pelvic diaphragm is a muscular partition between the true pelvis and the perineum. It forms a gutter-shaped pelvic floor. Its formation, it is formed by the following component. Most of the pelvic diaphragm is formed by levator ani, posteriorly by the coccygeus and pelvic fascia. So these structures are called pelvic diaphragm. Next is the function. Pelvic diaphragm supports the pelvic viscera and prevents their prolapse. Okay, that is main function. Sphincteric action, its fibers acts as sphincter around the vagina and at the anorectal junction, and it facilitates defecation, micturition and parturition. Next is the openings of pelvic diaphragm. Pelvic diaphragm has the following openings: hiatus urogenitalis and hiatus rectalis. Hiatus urogenitalis, it is a triangular gap in the anterior fibers of two levator ani muscles, and this hiatus transmits the urethra in male and urethra and vagina in female, and this gap is closed inferiorly by the urogenital diaphragm. Next is hiatus rectalis. It is a circular opening in the pelvic diaphragm. It is located between the perineal body and anococcygeal raphe, and it gives passage to the anorectal junction. Okay, so these are the openings of the pelvic diaphragm. Next, see, this is the pelvic diaphragm. This is hiatus rectalis, through which passes the rectum. This is hiatus urogenitalis, through which passes the urethra in male and urethra and vagina in female. And these are the structures forming the pelvic diaphragm. Levator ani, main part is the levator ani formed by iliococcygeus, pivococcygeus, pivoanalis, and other structures are this coccygeus, some part of the piriformis, anococcygeal ligament. All these are forming the pelvic diaphragm. Okay, understood? Next, injury to the pelvic diaphragm occurs rupture of the perineal body during parturition. Perineal body is the part lying between the vaginal opening and the rectal opening. The part of that muscle bulk lying in between these two openings, that part is known as the perineal body. Sometimes during childbirth it ruptures and there is direct connection between the rectum and the vagina. Continuous, there will be, in vagina there is no sphincter, so there will be continuous leakage of fecal matter. Okay. So this is a very dangerous situation. You must have to repair of the perineal body. So injury to the pelvic diaphragm, ruptured perineal body during parturition or childbirth weakens the pelvic diaphragm. It may result in uterine prolapse and rectal collapse. Hence, the repair of perineal body should be done after its injuries. Hiatus of Swalwell. It is an abnormal gap between the levator ani and the obturator fascia, and pelvic viscera may herniate through this opening. Okay, next. Next, we go to the pelvic fascia. Pelvic fascia are divided into these two following groups: parietal pelvic fascia, visceral pelvic fascia. Parietal pelvic fascia lines the pelvic muscles, and visceral pelvic fascia covers the pelvic organs and neurovascular bundles. Parietal pelvic fascia, it is a strong layer, covers the pelvic muscles. It includes the obturator fascia that covers the pelvic surface of obturator internus, fascia over piriformis muscle, fascia over upper surface of levator ani muscle and pelvic diaphragm, and presacral fascia that lies on the anterior aspect of sacrum. Next is visceral fascia or endopelvic fascia. It is also called endopelvic fascia. It consists of loose areolar tissue and fat. Endopelvic fascia condenses to form the following ligaments and structures. These are the ligaments. These ligaments are important support of the uterus. A support of uterus is very important, long question, okay, in your theory. So this endopelvic fascia condenses to form these ligaments: cardinal or McEnroe's ligament, uterosacral ligament, vesicosacral fold, pubourethral ligament, rectovesical septum in male, rectovaginal septum in female, parametrium and paracolpium. Okay, colpium means is lying around the cervix. So these are the important condensations of endopelvic fascia forming ligaments. Next, see here, some of those fascia have been shown. See, this is obturator membrane. This is obturator internus muscle originating from inner surface of the obturator membrane, and this is the fascia covering the obturator internus, which condenses to form this line from where the levator ani muscle is originating. Here it is forming a semilunar shaped line, arced line. From there the levator ani is originating. And there is also a fascia covering the levator ani muscle. There is this is visceral layer covering the bladder, and here is the parietal layer of the pelvic fascia surrounding the different muscles. This obturator internus muscle then covering this levator ani like this. And there are two pouches in the perineal region. This is superficial perineal pouch. This is deep perineal pouch. These two pouches are separated by inferior fascia of urogenital diaphragm, also known as perineal membrane. There is also a superior fascia of the urogenital diaphragm, and here is the Colles fascia Colles. Okay. So these are the important fascias lying within the pelvis. Next. Okay. So this is a section, sagittal section through the male pelvis, sagittal section of female pelvis. Here you can see the bladder. Here is the prostate gland, seminal vesicles. Okay, and this is rectum. So this is, here is the rectovesical pouch. This pouch is known as rectovesical pouch. This is the most dependent part of pelvis in male, and in female you can see three organs. In front there is bladder, then there is uterus and vagina, then there will be rectum anal canal. So there are two peritoneal pouches here, uterovesical and rectouterine. And rectouterine pouch is known as pouch of Douglas. Okay, that is the most dependent part of pelvis in female pelvis. Understood? And in between these organs, there is loose areolar tissue or endopelvic tissue, you can say, which condenses to form different ligaments. Next, obturator fascia covers the pelvic surface of obturator internus muscle. Attachments are superiorly attached to arcuate line of ilium. Further, the obturator fascia is attached to the bones along the margin of origin of the obturator internus muscle. Tendinous arch of Levator Ani, also known as arcus tendinous musculi, Levatoris Ani or white line. It is an arched line or thickening of obturator fascia, and that gives origin to iliococcygeus part of Levator Ani. Origin of iliococcygeus divides the obturator fascia into two parts. Upper part forms the lateral pelvic wall, lower part forms the lateral wall of ischium fossa. Next is fascia over piriformis. It covers the inner aspect of piriformis. It is very thin and has attachments. It fuses with sacrum at the margins of sacral foramina, and the ventral primary rami of sacral nerves are covered by this fascia. Okay. Next is fascia covering Levator Ani or pelvic diaphragm. So these two diaphragm are different. Pelvic diaphragm is lying above this Levator Ani, okay, and there is urogenital diaphragm which is lying below, which consists of two layers, superior fascia, inferior fascia, and inferior fascia is known as the perineal membrane. Okay, understood? And these two layers enclosing the deep perineal pouch. So these two are different. You remember pelvic diaphragm and urogenital diaphragm. You clear the concept regarding these areas. Okay. So both the surfaces, superior and inferior of the Levator Ani muscle are covered by the fascia covering Levator Ani, and these superior inferior layers of fascia and sandwich Levator Ani form the pelvic diaphragm. Superior fascia of pelvic diaphragm is a thick layer. It is attached anteriorly to the body of pubis, superior ramus of the pubis, and blend with obturator fascia. Posteriorly, it is continuous with fascia over the piriformis. Medially blends with endopelvic fascia. An inferior fascia of pelvic diaphragm is thin, forms the medial wall of the ischial fossa. Okay, so it forms a hammock-like fascia behind the rectum, okay, and anterior to the sacrum. Attachments are laterally the presacral fascia blends with the fascia covering piriformis and superior layer of fascia over Levator Ani and with obturator fascia, and anteriorly blends with fascia covering the perirectal pad of fat, that is mesorectal fascia, and inferiorly blends with the mesorectal fascia and iliococcygeal muscle, iliococcygeal fascia, okay, covering the iliococcygeal muscle. Next, in rectopexy for rectal prolapse, okay, when there is rectal prolapse, you have to pull back the rectum in its original position, and you have to fix the rectum with the surrounding viscera so that it don't come down through the anal opening, okay. So that operation is known as rectopexy. So in rectopexy for rectal prolapse, the rectum may be sutured with the presacral fascia. That is the clinical importance of this presacral fascia. Presacral fascia covers and adheres the presacral veins. Hence, surgery through the plane of presacral fascia may damage the presacral veins and may produce severe hemorrhage. Okay, so that is, you have to remember, there are veins and there may be severe hemorrhage. You have to be careful about these veins during rectopexy operation. Next is endopelvic fascia. It is a visceral layer of the pelvic fascia, consists of loose connective tissue and fat, anchors pelvic organs to the lateral pelvic wall. This is the function, provide passage to neurovascular bundle from pelvic wall to the pelvic viscera. holds the pelvic organs in place and prevents their prolapse, separates the adjacent viscera from each other. So these are the functions of the endopelvic fossa. And endopelvic fossa condenses to form these ligaments. First is cardinal ligament or McEnroe ligament or lateral cervical or transverse cervical ligament. It is a pair of panciped ligament that connects the cervix of uterus and upper part of vagina to the lateral pelvic wall. Next is uterosacral ligament. It is condensation of endopelvic fossa, connects cervix of uterus posteriorly to the sacrum. Next is vesicosacral fold. In male, instead of uterosacral, there is vesicosacral fold is present. Next is pubourethral ligament. It is a misnomer, extends from pelvic surface of pubis bone to the anterior wall of the vagina. Next is rectovesical septum in male and rectovaginal septum in female. It is a connective tissue that lies between rectum and seminal vesicle in male and rectum and vagina in female. Does not connect the rectum with the seminal vesicle or vagina. Next is parametrium. It is a part of pelvic fossa that surrounds the uterus, separates the uterus from urinary bladder, extends in between the layers of broad ligament and gives passage to uterine vessels and ovarian ligaments. Okay. Next is paracolpium. Part of pelvic fossa surrounds the vaginal wall and pubo-cervical and rectovaginal septums and gives passage to the vessels and nerves to the vagina. Okay, understood? Next is peritoneum of male pelvis. You have to know the disposition of the peritoneum. In male, the peritoneum passes downward from the posterior surface of the anterior abdominal wall, passes backward to cover the superior surface of urinary bladder, covers the posterior surface of urinary bladder up to the seminal vesicles, and further covers the seminal vesicles. It reflects backward from the posterior surface of bladder and seminal vesicle to the rectum, and here it forms a shallow pouch called the rectovesical pouch. Okay, and from the sides of the rectum, the peritoneum is reflected to the lateral pelvic wall, and here it forms the pararectal fossa. Okay, so this fossa and pouch is formed in the male pelvis. From the superior surface of urinary bladder, peritoneum reflects to the lateral pelvic wall, and here it forms the paravisceral fossa. Pararectal and paravesical fossa are separated from each other by raised peritoneal folds containing ureters and internal iliac vessels. Okay, understood? Next, in female, peritoneum in female pelvis, peritoneum passes downward from posterior surface of anterior abdominal wall, then it passes backward to cover the superior surface of the urinary bladder, then it covers the posterior surface of urinary bladder and reflects over the anterior surface of uterus. Here it forms uterovesical pouch. Two pouches are formed here. Uterovesical, then it covers the uterus and upper part of posterior wall of vagina and then passes backward to the rectum. And here it forms rectouterine pouch of Douglas. Okay, most dependent part. On either side of uterus, the peritoneum hangs from the uterine tube to form bilaminar folds of peritoneum called the broad ligaments. Okay, broad ligaments are formed by peritoneal reflection, important support of uterus. And ovaries are attached to the posterior wall of broad ligament by the force of peritoneum called mesoovarium. This is mesentery, also called mesentery of the ovary. Next, see here, this is the reflection. This is anterior abdominal wall. From here, it is reflecting over the urinary bladder, then covering half of the posterior surface of bladder, then reflecting over the rectum. These are forming rectovesical pouch, and this is rectovesical fossa, fossa of Dunning-Miller, formed by condensation of the endopelvic fossa. This is male pelvis because there is bladder, prostate, and rectum. This is female pelvis. Here reflection you see. This is bladder, uterus, vagina, rectum. So it is coming from anterior abdominal wall, covering superior surface of bladder, some part of posterior surface of bladder. Here it is forming vesicouterine pouch. Then it is covering the uterus, anterior, superior, posterior surface, some part of the vagina, then is reflecting over the rectum. Here it is forming rectouterine pouch. Okay, it is covering the posterior fornix of the vagina. Okay, okay, next. Okay, that's also that was discussion about the pelvic fascia. Okay, so from the today's discussion, to prepare pelvic diaphragm as a short note, important short note, levator ani, important short note, piriformis, important short note. Okay, and those reflection of peritoneum, different pouches, and those endopelvic fascia and formation of different ligaments, all these are forming supports of uterus. So that comes as a long question. You prepare supports of uterus as a long question. Okay, understood? So we have read different muscles, bones forming the different walls. We have seen different walls of the pelvis, their formation and the viscera. Okay, containing viscera within the pelvis and the different fascias and diaphragm, pelvic diaphragm, urogenital diaphragm. Okay, and those perineal pouches, superficial perineal pouch, deep perineal pouch, all this comes as a short note. Those are important short notes. Okay, superficial perineal pouch lies below the perineal membrane. Deep perineal pouch lies above the perineal membrane. Okay, in between the two layers of the urogenital diaphragm lies the deep perineal pouch. It is an enclosed space, and superficial perineal pouch is open below. Okay, in case of male actually, it connects with the anterior abdominal wall, also connects with the subcutaneous tissue around the scrotum and testis. Okay, scrotum, penis, testis, all these area. If there is rupture, then urine can accumulate within this space. It can extend over the anterior abdominal wall, also around the scrotum, penis, and other perineal region, surrounding areas. Okay.